Everyone. Good afternoon. Welcome back to our monthly critical care webinar series after a short break. We're happy to have you all with us once again. And today we have Dr. Jason Bartock as the speaker. Some of you are familiar with Dr. Jason. He has been with us before in this webinar series. He's also been a regular faculty in our regular courses that we've been having for the last 3 years in DAR on critical care and in the AfriKit conferences. So once again, we're very happy to have him join us again today and looking forward to learning from him. Today, he will be taking us through the management of DKA, a topic and a subject that every one of us has one time or the other managed in the hospitals. And I'm sure we'll have a lot of experiences to share later on. So thank you all for joining, and I look forward to this discussion later on. Dr. Jason, thank you for taking the time out today, joining us again, and sharing your expertise. And we look forward to your presentation.
Well,
As
it's
always,
great sorry. It's
yeah,
a wonderful introduction. It's great to see everyone. You guys hear me okay?
yeah, we can hear. Yeah,
Okay, good.
yeah. If anyone has any questions, please feel free to write in the chat, and we'll come to the discussion portion also at the end. So, Jason, whenever you're ready, please go ahead.
Perfect. I don't have a ton of slides this morning, and I am recovering from the flu, so I apologize if if I have a little bit of difficulty hearing or speaking. But I'm going to talk a little bit about the management of diabetic ketoacidosis, and I'm going to take it from the approach of truly understanding, excuse me, the underlying biochemistry of what's happening, right? The physiologic derangement as it relates to the underlying biochemistry. Because I think many of us, especially those of us who trained in medicine or emergency medicine, feel pretty comfortable in how we sort of tackle the treatment of severe ketonemia, right, or severe ketoacidosis. But do we really understand why each one of those applications, right, is so important to reversing the underlying biochemical derangement? So that's kind of the approach that we're going to take today. Wanted to do it a little bit differently than I've looked at it before, because I think it's kind of easy to say, oh, we give fluids and we give insulin and people get better, but why? And should we be, and how should we be thinking about, that very protocolized approach often? And I'm not sure how it works in many of your institutions, but certainly in ours, the management can be extremely algorithmic as we've built it into protocols that help us do what's best, but also take some of the weight off of constantly having to go in as the physician and make micro adjustments. But in order for us to apply a protocolized approach very well, we have to take a true systematic understanding of the underlying problem. So that's why we're going to talk about the biochemistry. So let me advance if I can. Okay, here we go. So I'm not going to spend too much time talking about the epidemiology of DK, but certainly it's a problem for us here in the States. It's about 10% of all of the admissions to the hospital with, what we call a DRG or a primary diagnosis of diabetes. About 10% of those will be for diabetic ketoacidosis. And it results in more than, 500,000 hospitalizations each year. And it's a huge, cost to our healthcare system, around $2.5 billion. Some of those certainly are preventable, as the ketoacidosis can be from insulin non-compliance, which, I really want to take a moment, while we're here is, to always remember that we try not to blame the patient. And I only bring that up because almost every week, working in critical care, I admit someone with diabetic ketoacidosis. And almost every week, even when the patient swears that they take their insulin, one of my residents or fellows will immediately blame the reason for their ketoacidosis on insulin noncompliance. And that may or may not be true, but it puts us at risk for missing underlying stressors, which is going to be a big part of this conversation, and why when we miss those, mortality can be surprisingly high in the ketoacidosis population, right? You see a mortality of 5%, and I think that doesn't seem so bad considering, we work in critical care and we take care of patients that are critically ill or injured, and a 5% mortality for many of the things that we see would probably be pretty good. But think about the 100 DKA patients at least that you've managed in your career so far. Did 5 of them die? I don't know, probably not. So I think when you think about, the way we manage and how simple it can be at times, a 5% mortality, it can be pretty concerning, since this is a process that seems so easily reversible. Take a little bit of a different perspective, right? How many patients do you see with pHs under 7 that you don't really get too nervous about, right? I mean, if it was any other patient being admitted to the ICU and they had a pH of like 6.9, I think you'd be pretty nervous. When we commonly see DKA patients with pHs of 6.9, and you just kind of say, oh, another DKA admission, throw some fluids at them, throw some insulin at them, they get better in 24 hours, and you discharge them. So again, there's a lot of opportunity to try to prevent anchoring, right, for biases related to, patient noncompliance and blaming the patient. And also, I think we should take a little heightened index of fear and insecurity around patients with extremely low pHs, and not always assuming that we'll be able to reverse them. And then honestly, being very mindful of them when we're forced to match physiology, which we're going to talk a little bit about. You guys understand at least the presumed underlying pathophysiology about, type 1 diabetes mellitus, right? For the autoimmune attack on the beta islet cells of the pancreas. And when you end up destroying about 90%, patients present with DKA. That's why I don't know if anyone has any type 1 diabetics in their family, but the onset traditionally is, in adolescence, right? So it doesn't happen as soon as you're born. You're not born with this disease. So we suspect this an underlying autoimmune destruction of the pancreas. And then as you lose those insulin producing cells of the pancreas, you end up, in DKA. And these type 1 diabetics, they don't really present with classic symptoms of diabetes, right? Which is, polyuria, polydipsia, and hyperglycemia, but actually, usually their first presentation to the hospital is in ketoacidosis, right? And now, certainly, there's a huge spectrum, especially here in the States, for later onset, type 2 diabetes, presenting more like type 1 diabetes as you build insulin resistance over time. So, just and understanding that once you either become severely resistant to the impact of insulin, and that's why we're going to talk about the biochemistry and each one of these hormones and their action and what they're responsible for, whether it's onset in adolescence or onset later in life. The underlying biochemistry is the same, and then the application of your treatment will be the same, and your heightened clinical index of suspicion for underlying causes should be the same. So metabolic derangement, this is insulin deficiency followed by glucagon excess, right? You are stuck, right, in a high metabolic demand state, oftentimes being called on by a stressor, be it infectious or cardiac or what have you. And you need ATP, right, to get through that. And you can't use glucose, right, in order to create energy. So what do you have to do? You have to go through fatty acid oxidation, right? And I don't want you to focus too much on each one of these enzymes in particular, but understand the pathway and understand where the application of your treatment is coming, right? So ketosis, fatty acid metabolism into beta hydroxybutyrate and acetoacetate is where your ketosis will come from, right? And then the primary places where you're going to do this is in liver, muscle, and adipose tissue. And these are going to be the primary players of where this whole, I guess you could think about it like a game. So who are my major players? You got to think about the hormones, insulin, glucagon, and stress hormones are all circulating, right? Low insulin, high glucagon, and in the setting of a stressor. And again, I'm going to continue to harp on this because some of the saddest cases that I've seen is when we've missed that underlying stressor, right? Be it an infectious stressor, be it a cardiac stressor, they should always be present until proven otherwise before we blame the patient for insulin noncompliance. Where do they play? So the major action of all of this whole biochemical pathway will take place in the mitochondria. The primary substrate will be acetyl-CoA, which, remember this or don't remember this. Really not all that important, but again, as we map out this biochemical pathway, and then we're going to talk about all of the enzymes that are part of it. All right, so we'll start off with a case. This is a real case. 19-year-old female presents with nausea, vomiting, has community-acquired pneumonia. She has no known past medical history, but she does report 10-pound unintentional weight loss over the past 2 months, along with polyuria and polydipsia. Her blood pressure is sort of borderline 90/60. Respiratory rate is high at 39, heart rate 116, setting 94% on 3 liters nasal oxygen. Serum glucose is 455, bicarbonate is 2, and metabolic acidosis is 38, pH is 6.9, and lactate is 4.2. What's your diagnosis? Well, this is a talk about diabetic ketoacidosis. So she has DKA. From a risk stratification standpoint, we do think about DKA in terms of mild, moderate, and severe risk stratification. For us, that's important because it has a lot to do with where we place the patient within the hospital. The DKA protocol is largely, universal when it comes to considerations for crystalloid expansion, the weight-based insulin dosing that we use, the frequency in which we check labs. But depending on the severity, it might be much more important for you to institute that therapy as early as humanly possible and make sure that that therapy is maintained at the highest level possible, especially in those severe cases. I'm sure all of you can appreciate the real world difficulty when it comes to sometimes getting IV access on these patients, maintaining IV access, being able to expand your intravascular volume while also infusing insulin in these patients when these IVs fail, or patients become more sick or difficult to deal with. Therapy can be interrupted, and if you're on more of a general medical ward type of support structure versus a step down level of care versus an ICU, you may or may not be able to tackle some of these issues better. So certainly in the moderate to severe population, critical care almost universally gets involved, if anything, to help guide therapy when it comes to risk stratification of underlying stressor like infection or cardiac, and then to guide resuscitation depending on other comorbidities, whether they may have concomitant heart failure, right? Or they may be end stage renal, which are two areas where some of our early responders may be wary of giving large volumes of crystalloid, and that may be detrimental to getting these patients better sooner, just based off of knowing that they have no kidney function or they have a reduced ejection fraction. Which honestly, for me, and we can talk about this at the end about what my approach is, not terribly concerned in those situations. And I use things like point of care ultrasound to help, anchor, where I feel they are in terms of volume responsiveness, because the volume expansion part of this, which doesn't get as much emphasis, is very important. And we'll talk about that in a second. Where our more mild DKA patient population will usually be able to be managed on the floor, and oftentimes can be managed with, with instituting subcutaneous insulin and not even having to go to a drip protocol. So you guys understand this part. We try to get 2 large bore IVs, one that we can resuscitate crystalloid through and the other which we can maintain insulin infusion. We expand that intravascular volume. We dose our insulin weight-based. We work to treat the underlying etiology. Again, those cardiac stressors are so important. Let me give you a couple of examples of ones that I always think about and talk to my residents about. I remember being a fellow, and of course, we were very busy at night. We were admitting a lot of very sick patients, and I had this young woman. She was 31 years old. She's a mother of 2. She's been type 1 diabetic for most of her life. Onset was around 6 years old. Very classic. Very first onset was diabetic ketoacidosis. And she reports being very well maintained her whole life. So she comes in pretty classic signs and symptoms of DKA, and gets seen by one of my co-fellows and gets signed out to me. She's not taking her insulin. She just needs to be put on the protocol. I started the protocol downstairs. Just go down, take a look at her, downgrade to medicine as soon as the gap closes, right? Very sort of, busy end of the night sort of handoff, no big deal. Well, I go down and I see her and I start to have a conversation with her. At that point in time, both the fluids and the insulin haven't been started because, she has difficult IV access. And everyone was really struggling to even get an ultrasound guided IV in her at the time. So once I was down there, I was finishing up the history intake and making sure that all of my orders were appropriate. And I basically asked her, well, what, it's unusual that you're in DKA. Have you not been taking your insulin? She's like, everybody keeps telling me that. And I keep telling them that I'm taking my sub-Q insulin. I haven't missed a dose, right? Even though I haven't been eating very much because of vomiting, I know to take my insulin because the last time I was in DKA, it was terrible. And I said, okay, well, how long ago was that? She said 5 years ago. And I was like, oh, wow, 5 years ago. So what happened? She's like, oh, I had this terrible sinus infection and I had to go to a different hospital over in Philadelphia for a major sinus surgery, which ended up being a sinus debridement. And she ended up having disseminated, excuse me, mucormycosis, right? So she had a major stressor at the time, a major infection with very high morbidity and mortality the last time she was in DK. And I was like, oh, wow, that's terrible. So while we're having this conversation, she's finally being bolused with volume because she was markedly intravascularly volume depleted. And as I'm having that conversation with her, all of a sudden, her eardrum ruptures and all of this green purulent material starts leaking out of the side of her head. She had recurrence of her mucor, and that's what tipped her over in the DK at the time. So we got her DK managed. She was seen by our ear, nose, and throat doctors and actually went for emergent surgery. So that was a really good example of anchoring, and not thinking about the underlying problem. And luckily, she did very well, but could have easily gone to the floor. That could have been missed, and we could have caught her late in her presentation, as we often do in critical care, working to resuscitate rather than reverse. Another one of my favorite examples of not forgetting about potential underlying stressors was a orthopedic surgeon. So this is one of the first patients I took care of in one of the first jobs I had out of training. He was a retired orthopedic surgeon and he had been a type 1 diabetic his whole life. He was 70 years old and he had very, very little sequelae of diabetes, other than a little bit of neuropathy, and a little bit of retinal changes. Everything else was perfectly well managed. And he was on an insulin pump. And he presented to the hospital in DKA. And basically the resident who admitted him told him that your insulin pump must be broken. He's like, wow, I've been using this insulin pump and I've gone through multiple pumps and I know when they're not working. And I'm telling you, it's working just fine. And then she was said, no, it must be the pump, because otherwise you look great. There's no other reason for you to be in DK. It's obviously your pump. Well, when I'm sitting there having the conversation with him, thinking back to that young girl that I'd seen in training, I asked him, I was like, so tell me about the last time you were in DK. And he's like, oh, it was several years ago, probably 3 or 4 years ago. I was like, oh, well, what happened? Did your insulin pump break? He said, oh, absolutely not. I had a heart attack. And I said, oh my goodness, that must have been terrible. And he's like, actually, I didn't feel a thing. And I said, oh, no kidding. He's like, yeah. All they did was they noticed that I had T-wave inversions and then my troponins were elevated and at 100% occlusion of my LAD that they went in and stented. I was like, oh my goodness. Well, that's really interesting. So I open up his chart and in there is an EKG and he has inferior, pretty deep, I shouldn't say that. They were pretty mild ST depressions with T-wave inversions in the inferior leads. Now, we see a lot of abnormal EKGs in the ICU, and this one for a guy who was otherwise asymptomatic wasn't terribly abnormal. However, when compared to his baseline EKG that you could see in his outpatient office from just a month before that, it was completely abnormal from his baseline. We checked the troponin, it was sky high. Excuse me. And he went for cardiac cath and he had a 90% occlusion of his RCA. So he was basically having an NSTEMI And that was his reason for being in DK. So never forget about the underlying etiology and really do your job as doctors to drill down those risks so we don't miss that. And that's what drives the mortality up. And then certainly we have frequent glucose monitoring, BMP checks, and electrolyte replacement. Now let's talk about why these treatments work the way that they do as it relates to the underlying biochemistry. Volume expansion is very important. One of the things that people talk about is, certainly you have hyperglycemia, which leads to an osmotic diuresis, right? And that osmotic diuresis will oftentimes, on average, have your DKA patient present maybe about 4+ liters negative, right? And you should feel pretty confident about targeting an expansion somewhere around there, to reverse that intravascular volume loss. Um, the reason why it's important for us to expand the intravascular volume, certainly for that volume loss. One of the concerns that I think is drilled down in the emergency room is that if the patients are markedly intravascularly volume depleted and you start insulin, and that allows those glucose transporters to be activated, and you bring glucose into the cells, it can bring free water in with it, and then can lead to episodes of hypotension. I can't say honestly that I've ever seen that in my life, but it's definitely something that is taught frequently. I think what's more important when it comes to volume expansion is to think about, does it help the ketoacidosis, right? We are here to treat DKA, right? And the biggest problem that we're dealing with is the A, right? It's the severe acidemia that's the problem. So, yes, we lose a lot of volume and we think about replacing that volume. But one of the reasons why being vigilant, right, about volume expansion, these patients are normally macrovascularly intact, right? So they have normal blood pressure, and you want to give volume back, but you really want to be aggressive to get to a euvolemic state because it helps with the acidosis, right? And I don't think anybody ever really talks about that. So think about it like this, right? What is pH, right? pH is the concentration of protons in a volume, right? All right. That's what your pH is. It's concentration of protons. So you have a number of protons in, let's just say, a fixed volume. So what happens when you take the same number of protons and you expand the volume? Well, it definitely will improve pH, right? Because you'll have the same number of protons in a larger volume, and pH will go up. So, when you see that marked acidosis up front, and there's a lot of considerations for bicarbonate, and we can talk about that in a second. Really, one of the things that you need to do is be aggressive for the things that we know are beneficial, and that is volume and insulin. And the volume expansion part of it is part of the acidosis treatment. And I want you to think about it as part of the acidosis treatment, because by expanding the intravascular volume, while you also work to shut off hydrogen ion production, will help improve pH. Everybody with me? All right, good.
Yep.
All right. So now, yep. Any questions? So let's sort of map out the biochemical pathway. So stick with me on this, okay? I don't need you to remember any of the enzymes involved. Just let's talk about the major players and where the action of insulin takes place, okay? So you can't use glucose to make ATP. So what do? Your body is smarter than you are, right? It's going to find a way to make energy to keep you alive. So it goes, to those stores in the body which are richest calorically, right? Which is fat, right? So it's going to go to your adipose tissue and it's going to liberate fatty acids so that we can convert that into ATP, since we can't use glucose, right? In the absence of insulin activated glucose transport, right? So you go to your adipose tissue, right? You have glucagon excess. That glucagon upregulates hormone sensitive lipase in adipose tissue, and it produces fatty acid, right? Those fatty acids are then transported to cells, right? To the mitochondria, which, if everyone remembers basic biochemistry, is the power plant of the cell. That's where ATP is produced. Those fatty acids, not exactly the most efficient process in the world, are albumin bound, and they're transported to the mitochondria. And when they get to the mitochondria, we remember the mitochondria is a double membrane bound organelle, right? Has two transporters on it. not so important for you to understand, but just understand how much work goes into this process, right? You have to liberate fatty acids from fat. Then you got to transport them in the serum to cells and then get them into the mitochondria via these two active transporters so that they can get inside of the mitochondria to the TCA cycle, right? Where that acetyl CoA can be converted into ATP. Beautiful. The biochemistry of how we make energy in the absence of glucose. The downside to this is that, you know, that this pathway certainly is saturable, right? And in the presence of a stressor, right? Whether it's lack of exposure to insulin over time, where this will build up and saturate the TCA cycle, or you have upregulation of, let's just say, biogenic amines in the setting of stress, like cortisol, epinephrine, norepinephrine, right? That's going to really upregulate, right? So you have epinephrine, cortisol, growth hormone is really going to upregulate that enzyme, hormone-sensitive lipase, and start shedding fatty acid like crazy. Because your body, like I said, is smart. It knows it needs energy. I am stressed. I am dying of infection. I am having a heart attack. Something is bad. I need as much energy as possible to keep this human alive. So I'm going to send out these biogenic amines. I'm going to upregulate this system, and I'm really going to saturate very quickly, right? And that's where the tempo of DK is also important. Sure, you're going to meet people who are very brittle and can, have an anion gap of 45 in no time just by not taking any insulin. But also think about the tempo and the rate in which, they were doing fine 12 hours ago, and now all of a sudden they're very sick. And, you have a high amount of liberation of these stress hormones, and then we saturate this process very quickly and start producing ketones. Maybe there's something else driving it, like infection. Another example I can remember is, years and years ago, I walked in the emergency department. They called me for a DKA admission, and she see me in the ER doctor, which was very interesting. He's like, "Oh my goodness, like I could smell ketones from the door." So I knew she was in DK. I checked labs and I called you. That was a good way of saying I never examined the patient, right? I could smell ketones from the door. Now, you can certainly smell ketones on someone's breath. I've never smelled them from the door before. So when we went in the room, it turned out that the patient had Fournier's gangrene, so a necrotizing deep soft tissue infection, of the genital area, and that was what you could smell from the door. So another good example of, think about underlying stressors. So I'm losing you guys here, and I apologize. So fat to fatty acid to the mitochondria, active transport via CPT1, CPT2, liberation of acetyl-CoA to the TCA cycle, and then making ATP. Now, like I said, this is going to be saturated, right, over time. And you can only produce so much ATP via that pathway. So what do? Die? No, you don't die. Your body is smarter than you, so it finds a different way to shunt, right, that fatty acid pathway to produce something, right? So there's another HMG CoA enzyme that you don't have to remember the name of, right? But that's where ketones are produced, right? And that's where the ketones result in your ketoacidosis, right? So you ask yourself, are ketones good or bad? Well, they're good, right? They're bad for you when it's 3 o'clock in the morning and you have to admit somebody, but they're definitely good in the sense that if you didn't have them, you would die, right? Ketones are also great because they can freely diffuse into any tissue in the body and be converted backwards, right, into ATP. So you need ketones in order to survive. The downside to a ketone, it has a low pKa. We don't have to talk about chemistry or anything like that. But with that, when they hit serum to be transported, they liberate a proton, right? And that is where your acidosis comes from, right? So over time, through the transport of ketones to the places they need to go, you liberate protons and you develop acidosis. All right. So this is the classic biochemistry of DK. All right. So you can think about ketones as sort of two-faced. They're great because they keep you alive. They're bad because they kill you from acidosis, right? So the idea here is we got to fix this over time. All right. So let's talk about where insulin therapy is important, right? So, when you guys approach these patients, you think about their intravascular volume status, you start to aggressively volume expand them. That will not just help, expand tissue and maintain perfusion, right? But it will also help, hopefully improve pH by expanding total vascular volume. And then you start your insulin therapy, and you start at a relatively high weight based, right? Insulin. And one of the important parts of that is you want to maintain that insulin at a high level. In the protocols, we have a number of safety mechanisms built in where you can titrate down your insulin, right, as glucose goes down. Now, notice in this whole biochemical pathway, hyperglycemia was never mentioned, right? Hyperglycemia has nothing to do with keto acid formation, right? Hyperglycemia is sort of is a flag of a lack of insulin. And yes, hyperglycemia will destroy tissues over months to years, but it's not a problem in here. In fact, you want to keep a patient's glucose high so that you can maintain as much insulin as possible. And this is why, right? When we institute insulin, where does it work, right? So one of the first places insulin works is it attacks that HMG-CoA enzyme that produces ketones, so it shuts off ketone production. The next place that it works, and then we lose all of our protons, right? The next place that it works is that it inhibits both of those CPT transporters and prevents fatty acid from entering the mitochondria to be converted into ketones, right? It downregulates glucose production, right? Your job is to fix your underlying stressor. You're going to lose your cortisol and your epinephrine as you say treat infection, right? But then the insulin will downregulate glucagon and downregulate the production of fatty acid from fat via downregulating hormone sensitive lipase and upregulating lipoprotein lipase. So you no longer are producing fat to fatty acid from adipose tissue. The whole cycle is being pushed backwards, right, by the institution of insulin. A good example of this is think about in your outpatient office. When you start a patient on insulin therapy, what's one of their first complaints? I can certainly say when, I don't work in the outpatient setting anymore, but when I did, when I would start somebody on insulin, one of the first complaints that they would have is weight gain. And you can understand that as you're shifting, right, and down regulating the liberation of fat to fatty acid, right? So your fat stores may go up and they may gain weight if they're not trying to maintain a healthy exercise balance and everything they should along with it, right? So it's very important, to maintain that insulin level as high as you possibly can, because the more aggressive you are with your insulin dosing and duration, the quicker you're going to shut off this ketone pathway and alleviate, right, the acid production and close your gap, which is your job, right, as the provider, is to close that gap as quickly as possible so that I can get the patient on sub-Q insulin so I can either downgrade them or discharge them home, right? So this is very important. And one of the things that we all try to do is we try to maintain that glucose level up so that we don't have to decrease our insulin dosing so we can be more efficient. And that's where, you'll see the protocols call for, dextrose containing fluids very early. Some of them will say when the glucose drops below 250, start, switch your whatever your infusate is. If you still think that they need isotonic volume, it would be dextrose and isotonic fluid. If you think that they are euvolemic, you may use dextrose and half normal saline. But you try to add dextrose back in order to drive up the patient's glucose level so you can maintain that insulin therapy. I usually start it when it drops below 350. I want to keep that glucose level in a safe range because hypoglycemia will kill you, right? So I don't want to downplay the need to prevent hypoglycemic events. But I definitely institute glucose earlier, right, around 300 or 350, so that I can maintain that glucose level above 250 so that my nurses don't start to down titrate my insulin dosing, which then will extend, right, the duration of my treatment because I'm not closing that gap as efficiently. Everybody with me? All right. So that's that. There's a lot of, of nuanced topics about sodium bicarbonate. Now, clearly you have severe acidosis, and these can be life-threatening pHs. And people get very nervous when the pH is less than 7, and the bicarb oftentimes can be 4 or 2 or even 0 on your chemistry, which we've all seen before. And thinking about the addition of sodium bicarbonate, what I can say, and that sort of remains true for all of the evidence out there, is we've never been able to show any benefit for the institution of bicarbonate, both for mild and severe ketoacidosis. The things that we worry about is oftentimes you do have a combination of ketone production and lactate production, and both of those things take some time to reverse. That severe acidosis can cause myocardial depression. So certainly a consideration, when we think about precision medicine, right? And that means understanding the data for all comers and then occasionally stepping outside of that and tailoring it to your patient. So if I have somebody who say is, excuse me, that's like chronic advanced heart failure, with a low ejection fraction on milrinone therapy, I may be a little bit more aggressive of raising their pH, if they have severe acidemia in the setting of DKA because of myocardial depression, right? Or low systemic vascular resistance might make them, more predisposed to shock than your average person, right? Certainly, you think about the left shift and the drop in 2,3-DPG, and you have less, you're less efficient at liberating oxygen and maintaining tissue perfusion. All those things are good benchtop considerations for the addition of bicarbonate. But like I said, um, we've never been able to show real benefit outside of our standard DKA treatment. Um, and what we have seen is by adding bicarb, you do have evidence of impaired ketone metabolism. So it may take longer for them to clear their ketosis. There's always the argument that you add bicarb to protons, right? Obviously, you make H2CO3, and then you make water and CO2. And the argument about adding bicarb to patients in active acidemia is that you can produce CO2, which then can then freely diffuse into cells and tissue and cause intracellular acidosis, which you can't see, right, by measuring serum pH. And that intracellular acidosis may actually make things worse, like myocardial depression. And one of the places that we've definitely seen that in is, when you have continuous CNS monitoring in some neuro ICUs, you can actually see a drop in brain tissue pH. It's certainly one of the things that we think about with CNS acidosis. And then, although you have your acidemic and you can have shifting of potassium, patients tend to be total body potassium depleted. And unless you're being very cautious with the addition of bicarbonate, you can have further shift backwards of that potassium without adequate supplementation of potassium, which we all end up having to do as we progress through our DKA management, and that potassium drops below 4.5. We start to replace potassium because these patients are total body solute depleted. And if you are a little bit overly aggressive with your bicarbonate, you can end up in a hypokalemic situation very quickly. And then that can lead to, oftentimes with case reports, of fatal arrhythmia. So there isn't a lot of good evidence for the supplementation of bicarb. If you have that really sick patient that has a raging infection and terrible ketogenesis, so you have, and your pHs are approaching that non-survivable range in that 6.8, 6.7, yeah, I still think a lot of us are going to use bicarbonate, but that's more of a precision medicine case by case basis. The overall recommendation would be to not utilize bicarbonate. I think people have seen the American Diabetes Association sort of stance on that. They are very open with the fact that they lack good evidence. For pHs less than 6.9, you can give bicarbonate. So you'll give a small challenge of bicarbonate over 2 hours just to get that pH above 7 and then stop. That's probably a safe place to be if you're worried. You add a little potassium to that to hopefully prevent you from having any arrhythmia related to hypokalemia. So a little potassium, 100 MEQs of bicarb, and a little bit of water. Get that pH above 7 after 2 hours and then stop. I guess that's reasonable. In reality, in my own practice, I can only think of ever having to use bicarb in very severe cases, and those were primarily driven by a secondary stressor causing a lactic acidosis as opposed to the pure ketogenesis. Because with aggressive volume expansion and early implementation of my high dose insulin, I can shut down my ketone process relatively quickly. And I haven't really felt the need to ever supplement bicarb. So if I am doing it, it has to do with secondary acidosis, oftentimes from lactate in the setting of those patients with, say, a severe necrotizing deep soft tissue infection, as I try to resuscitate them because they're usually in shock on top of that, and then figuring out how to get them out of their shock state and into a place where they can have definitive treatment. So let's go back to our case. So you have your 19-year-old female who presents with nausea, vomiting as a flare. Oh, I forgot to change this. This is actually a real case, but she has. I went from she had a terrible herpetic infection with active pubic lice. I meant to change that to community-acquired pneumonia because nobody wants to hear about that stuff anymore. But she reports with the unintentional weight loss and polyuria, polydipsia, blood pressure gap. We know that she has DKA. So we admit her, we put her on our DKA pathway. She arrives to the ICU, and this is a real case. A very enthusiastic first-year fellow sees her breathing rapidly, sees that she's a little disoriented. Yes, she has a burden of infiltrate via pneumonia, and decides to intubate her. So she's intubated using etomidate and rocuronium and placed on conventional settings, PRVC, 8 cc's per kilo, respiratory rate 16, PPO5, 100% FiO2. At the completion of intubation, she was hemodynamically stable, saturating 100%. The fellow walked out of the room, and then 5 minutes later, a code blue was called. The patient was in cardiopulmonary arrest. What do you guys think the underlying cause was? Anybody? Well, we forgot to match physiology. And this is something that I think is important. I've seen this a few times in patients with severe acidosis. You know, clearly she is maintaining a pH of 6.9 by breathing 39 times a minute. And she's young and healthy. I would anticipate that her minute ventilation, right, was probably 20 liters, right, or more, right, as she was breathing rapidly and deeply, which is what you see in these patients with severe acidosis. This fellow intubated her and then placed her on conventional settings, right, dropping her minute ventilation significantly by paralyzing her, putting her on a respiratory rate of 16 at 8 cc's per kilo, thereby dropping that pH from 6.9 probably to 5.5. And she had an acidosis-induced PEA cardiac arrest. Luckily, she was able to, we bolstered her with some bicarb actually, bumped her minute ventilation up as high as we could safely on the ventilator, got ROSC. She did very well, treated the acidosis, extubated her. She was discharged, and then we saw her again about a month later with DKA due to ongoing infectious issues and a lack of insulin compliance. But never forget to match physiology. When these patients get really sick and we we take sort of our standardized approach, sometimes we miss our opportunity. And when we don't match physiology, when they decompensate and we take over control, that's where that mortality rate really starts to skyrocket. So in the approach, expanding intravascular volume, very important, right? Yes, you want to replace volume lost via the hyperglycemic osmotic diuresis, but also expanding intravascular volume can aid in improving pH, which is I don't think is something that we think about a lot. You want to initiate your systemic insulin therapy and do your very best to maintain that dose as high as you can by supplementing glucose early, because we see that the better we tackle the problem with insulin, the better we are to turn off each one of those enzymes in the pathway for ketone production, and the quicker each one of you will be able to close your anion gap and get your patient transition to subcutaneous insulin. I would always take it that a stressor is present until proven otherwise, really thinking about infectious and cardiac risk factors, right? And whether or not something is present. Don't always blame the patient. The hyperglycemia is an incidental finding in this case. I would much rather have them be hyperglycemic than hypoglycemic, because it allows me to be more aggressive with my therapy. And always be prepared to match physiology when the patients decompensate, keeping in mind how hard they're working to maintain that barely sustainable pH that we oftentimes are not overly concerned about, because these patients do so well until they don't, right? And I don't really feel that there's any true role for sodium bicarb if you do your job right. Um, Now, again, think about where the evidence is, think about your systematic approach, right, to tackling this problem and using best evidence. And then if you need to step outside of that and think about precision medicine, right, which is tailoring medicine to a particular patient, if they have higher risk factors for myocardial depression, if they are in shock from an underlying stressor, and you don't feel that you can provide adequate tissue perfusion and ketone reversal, and that this acidosis is sort of equally weighted and combined, you may consider using bicarb until you can adequately resuscitate, stabilize. Again, precision medicine, but I would not recommend the use of sodium bicarbonate for any of my straightforward DKA patients, sort of irrespective of what that pH is and what that baseline bicarb level is, because I think that with aggressive volume expansion and early institution of high dose insulin, you'll be able to correct that pH relatively quickly. And that's all I have. Any questions?
Right. Thank you, Dr. Jason. Yeah, anyone have any questions, please feel free to unmute yourself and you can ask. Yeah. Maybe if I can start. So in your experience, what would be a rough approximate? I know this might be a bit hard to answer, but what would be an approximate time that someone would require to remove a patient from DKA? Say, for example, if 2 days pass and you have not removed the patient from
Yeah,
DKA, is that okay with you?
I think, yeah, in my personal experience, right, as long as I don't have, similar to, like, thinking about, sepsis and underlying issues, if I have good source control, right, so that there isn't a stressor or was maybe a UTI, and I put them on antibiotics immediately, and I'm able to aggressively get them through. 12 hours. I should really see that gap close within 12 hours, 12 to 24 hours, if it's all purely ketone production. Soon as I'm able to support that patient to utilize glucose to make ATP, their body is going to flip over immediately, because that is the most efficient process for them to then make energy. So I'm 12 to 20 hours. And if you're really finding it hard to close that gap, start to think about, well, what else is driving this? And then think about, if you're really fighting against, a particular stressor that hasn't otherwise been teased out.
Yeah, makes sense. Yeah, thank you.
Or that maybe you've struggled with maintaining your insulin dose at at a high enough or adequate dose. And I found that where, I start the insulin drip, and then because of brisk hypoglycemia, or glucose is dropping below the 200 range, you come in the next morning and they've been running on, 1 unit when you started them at, say, 12 units an hour, and they've been running on 1 unit per hour, basically since arrival because of the protocol. And then you know that you've just been underdosing their insulin significantly. So underdosing of insulin, I think, is one of the things that really extends the amount of time, to clearing acidosis and gap closure. And sometimes that has to do with not being aggressive enough in your glucose replacement. There is a lot of varying opinions on whether or not you should feed these patients. So provided that they're no longer nauseous and vomiting, there are plenty of people who I know who are more than happy to start a diet long before the anion gap closes as another efficient way for them to keep their glucose up high and close that gap as soon as possible. Feeding them on an insulin drip can be a little bit tricky. It's not because it's wrong. The only thing that can be tricky when feeding them is that your insulin doses can bounce around a lot, right?
Right.
The benefit of being NPO and using a continuous dextrose infusion and maintaining your insulin infusion is so you have a better understanding about what their requirements are going to be in order to bridge them. So I honestly am pro feeding on an insulin drip, but unfortunately, due to the complexities of nursing care and how frequently they need to augment the drip as a result, we don't feed our patients as part of our DKA protocol until
I
their
think we have,
gap is closed.
yeah,
Yeah,
thanks. I think we have a question on the chat as well. What would be your approach
sure.
to the patient who has DKA but also has end-stage renal disease but has not started
Yeah.
dialysis?
Yeah, that's where, point of care ultrasound is really helpful. I mean, they tend to be very leaky. They're in DKA. I mean, volume status and those, and trying to understand whether they're volume tolerant or intolerant. They're not going to have the same degree, certainly of of hyperglycemic osmotic diuresis, but they still tend to have intravascular capillary leak, and they depending on how compliant they are and how they run their dry weights, through dialysis, can very easily show up, similarly intravascularly volume depleted. If they're on room air and there's no pulmonary compromise, I'll use point of care ultrasound to look for volume tolerance. If they look volume tolerant, I'll still be aggressive with expansion, but rather than ordering 3 liters up front, I'd probably order a liter, look for volume responsiveness, again, reassess tolerance, bolus another liter, look for responsiveness, and then assess tolerance. And similarly, they're going to be a little bit more difficult, for them to match their own physiology, by augmenting, bicarbonate loss via the kidney. So that might also be a situation where you may even consider, if the acidemia is severe and their intravascular volume status is stable, whether or not you would, dialyze them to maintain pH if you have access, or you may consider a little bit of bicarbonate up front for them as their isotonic fluid of choice, just to maintain their pH until the insulin therapy can take over. But they can be tricky. The dialysis patient can be tricky because they're certainly prone to systemic acidosis. They have limitations for matching physiology, from a kidney acidosis standpoint, and volume status can be tricky as well. So you're really reliant on your insulin dosing to prevent worsening, ketogenesis, and then to reverse that underlying cause. So you may need to buy time. I personally I can't think of a single case, and I do get a number of end-stage renal patients who come in DKA. I haven't really thought of a single case um, where I've had to use sodium bicarb, but I also have access to dialysis 24 hours a day. So if I needed to dialyze them to help match physiology while I treat ketoacidosis, I've been able to do that. So I think I've been lucky in that sense.
Right.
Yeah, that's a good question.
Another interesting question is that we normally Jesus to use ABGs, the pH, to diagnose and also monitor the treatment of these patients. But most of the hospitals here don't have ABG machines, or even if they do have, it's not easily affordable by patients. So we normally use urine ketones and sometimes the blood glucose levels to make decisions. So what would you recommend in such situation
Yeah,
where you don't have
that's
ABGs
and
available?
there's plenty, outside of having access to ABGs. I mean, depending on there's other hospitals that we work at where you can't get a serum ketone level, either beta hydroxybutyrate or an acetone level. With sometimes it takes days. So you're similarly, we're going off of chemistry, off of clinical presentation, and off of presence of ketones in the urine. Yeah, can you have ketones in the urine strictly from starvation? You sure can. But I think a lot of this really, almost to our own detriment, right? Here in the States, is that we get people who, I'll be honest, out of the, maybe 10 or 20% of the DKA admissions that I get actually aren't in DKA, right? A doc will get a blood gas and look at a chemistry and see ketones in the urine, and they end up not being in DKA, and they admit because they didn't actually take a history. So I think your ability to take a history and look at the presenting symptoms and make sure that it fits diagnostically with the presentation of ketoacidosis, and then looking to your labs like we're all taught to do, I think is much more powerful than having access strictly to ABG. And I think here in the States, sometimes we do a really poor job, because it's an easy admission criteria, when in fact, I I frequently see patients who I get called for as DKA, and they're actually not in DKA. And the only reason why I know that is because I talk to them. You know what I mean? So I think, utilizing your history taking and your urine ketones is very powerful. And that's probably all that you need. And as long as you keep their glucose up and you use your insulin therapy, you're not going to hurt the patient, right? And whether or not if there's any question around if this truly is DKA. And then I think you can monitor serial ketones in the urine, and then once that sort of closes along with whatever your anion gap is, then I think you're good to bridge. And I'm sure that's what you guys do, and I think that's all that you need to treat this, because we've been managing DKA for a very long time, long before you had access to a lot of ABGs and point of care ABGs. We've almost become too reliant on chemistries to tell us if patients are improving, when we could probably go to the bedside and look at their perfusion status, look at their mental status, see how if they're if the nausea, the vomiting, and all the abdominal pain, all the things that we tie to this are getting better. I think that's a much more powerful marker, and oftentimes I think it's not something that we spend enough time doing.
Yeah, one more question is on the choice fluid. So the debate between Ringer's lactate and normal saline.
Yeah,
What would you say about
there's really no debate. I mean, isotonic crystalloid for me is isotonic crystalloid. Now, certainly, I think you can make the consideration that high volume normal saline, and then the concern for hyperchloremic metabolic acidosis. The reality is, for me, solute expansion is solute expansion. So certainly in our practice, and some of the data for critical care and sepsis, balanced crystalloid infusions seem to be a more thoughtful approach. So, almost it's almost strange to see normal saline being given in our ICU or in our hospital anymore. And the lactate and Ringer's lactate is never a concern for me. It's just a solute. So it's never really, being impactful or driving, worsening acidosis. So I, for me, I don't think there's any debate. You use what's available to you, because I still think that, this is a time dependent rescue type of situation. And the earlier you implement appropriate therapy, the better your patient will do. So I think a lot of people can argue, Ringer's lactate over saline or saline over Ringer's lactate. For me, it's all about isotonic crystalloid. Use what you have, and the patient will do better.
it? I think we can take one more question. What would you do in cases of DKA with hypokalemia on insulin?
Yeah, those are the hardest ones, right? Where you are forced to hold off on the insulin drip or pause the insulin drip. I'm very aggressive with my potassium replacement, even in my end stage renal or my CKD patients. For me, I'm again, I will double down on targeted volume expansion using point of care ultrasound, and targeting volume expansion to the best of my ability. Because I think that's something that I can certainly help the process while I wait for potassium replacement to a place that is safe, which would usually be keeping that K above 2.5. Now, certain protocols are built to pause when the K drops below 3. Again, this is sort of, for me, it depends on how sick the patient is, how bad the acidemia is, and and am I able to get them to a better monitored setting? Certainly that the hypokalemic risks for fatal arrhythmia are real. So I would replace that potassium to try to get that K above 2.5 to 3 before turning on the insulin, because those patients are total body potassium depleted oftentimes, and you can elicit an arrhythmia. So if they're able to take PO, in combination with IV, but I'm trying to get 100 plus milliequivalents hanging and running, and then a BMP within an hour to 2 hours, so that I can get that K up and get that insulin drip started.
Thank you. Thank you, Dr. Thank you, everyone, for your questions and your interaction. I know there are probably more questions, but we'll have to stop here because of time. We can always revisit this topic again in the future.
Absolutely. It was great to see
Dr. Jason,
everybody.
thank you once again, and
Thanks for
hope you
your
get
time.
better from the flu.
All right, Professor. Me too. But it was
you know,
great to hear from you. Great to see you.
Yeah, same here. So I hope we all see you all again next month for the next webinar. Take care, everyone.
Excellent. Take care, guys.